So in CLL, the eradication of detectable minimal residual disease, or MRD, is a key endpoint for many trials, and that we know that over the last 20 plus years that in any therapy where we eradicate detectable MRD, we have a better outcome. So we can use MRD as an endpoint in trials certainly for certain therapies to show that they're better than the comparators. We're now using it, particularly in FLAIR, to guide therapy. So we're defining the duration of therapy by MRD response, and that's certainly what the interim analysis of FLAIR showed, that we can use that to define how long we should treat a patient. As we speak at the moment, outside a clinical trial, I don't think there's evidence that we should be using MRD to guide therapy. But I think over the coming years, looking at the data that's out there in a number of trials that are now recruited and are reporting, I think MRD will be used to define the duration of therapy or to make decisions about subsequent therapy in patients who remain MRD positive. Certainly as a prognostic, as a predictor of outcome for an individual patient, certainly with regimes such as the venetoclax combinations, either with obinutuzumab or BTK inhibitors, it's a very strong predictor of whether the patient will remain in remission for a prolonged period of time. And I suspect, looking at the data, may be a strong predictor of cure.